की केयर का आविष्कार हुआ और ये फर्स्ट वर्ल्ड वॉर में इसका उपयोग हुआ। और उसके बाद 1950 में रस ब्रदर्स फ्रॉम ऑस्ट्रेलिया उन्होंने आविष्कार किया और इसको बोन फोर आर्म फ्रैक्चर में उपयोग किया गया। उसके बाद इंटरलॉकिंग का जमाना आया और इंट्रापर्सनल रूप से इंटरलॉकिंग शुरू हुआ, जिसे केम्प ने पॉपुलराइज किया 1970 में। और उसके बाद इंट्रापर्सनल रूप के बाद जो बीच में प्लेटिंग का दौर आया, जिसमें शुरुआत में हेवी ड्यूटी प्लेट का यूज किया गया, फिर डायनेमिक और कंप्रेशन प्लेट को यूज किया गया, फिर लो कॉन्टैक्ट LCDCP का यूज किया गया। उसके बाद एडवांस इंटरलॉकिंग करने जमाना आया। पहले इंटरलॉकिंग नेलिंग केवल डायफिशियल फ्रैक्चर में यूज होता था, फीमर का हो चाहे टीबिया का हो चाहे ह्यूमरस का हो, लेकिन बाद में मेटाफिशियल फ्रैक्चर के लिए भी एडवांस इंटरलॉकिंग शुरू हुआ, जैसे कि लोअर एंड ऑफ द femur and upper end of the upper third of the femur, subtrochanteric fracture, trochanteric fracture and supracondylar fracture के लिए DFN, supracondylar fracture के लिए DFN और subtrochanteric fracture और trochanteric fracture के लिए TFN यूज होने लगा। फिर TFN A आया और ऑस्टियोपोरोटिक बोन के लिए TFN A2 आया, इसको यूज होने लगा। आजकल ऑस्टियोपोरोटिक बोन का ऑस्टियोपोरोटिक पेशेंट में TFN A2 ही यूज करते हैं। और मेटलर्जी के बारे में शुरू में स्टील का उपयोग हुआ, जो ये तो बहुत स्टीफर होता है, about 10 times स्टीफर देन द कॉर्टिकल बोन ऑफ द ह्यूमन बॉडी। तो ये लोड बियरिंग हो जाता है और लोड शेयर नहीं करता है ह्यूमन बॉडी से। तो कैलस जो बनता है उसमें वीक बनता है। इसके बाद टाइटेनियम में नेल्स, जो नेल्स बनते हैं वो टाइटेनियम एलॉयज के बनते हैं और उसका मॉडुलस ऑफ इलास्टिसिटी ऑलमोस्ट सिमिलर होता है कॉर्टिकल बोन के मॉडुलस ऑफ इलास्टिसिटी के बराबर होता है, ऑलमोस्ट सिमिलर होता है। इस तरह से उसको एलॉय बनाया जाता है या इस तरह से मॉडिफाई किया जाता है। सो इट इज मोर बायो फ्रेंडली एंड बायो कंफर्टेबल। उसके बाद आया और कार्बन फाइबर्स का, तो कार्बन फाइबर्स का बिकॉज इट इज ट्रांसलूसेंट, इट इज नॉट रेडियो ओपेक, so it is very useful in cancer patients, pathological fracture due to bone tumor। उसमें क्या प्रोग्रेस है ट्यूमर का, जो ट्रीटमेंट दिया जा रहा है उससे इग्नेशन हो रहा है कि नहीं, चारों तरफ ट्यूमर के हम लोग देख सकते हैं। और फ्रैक्चर का कैलस बन रहा है कि नहीं ये भी देख सकते हैं, क्योंकि ये रेडियो ट्रांसमिशन होता है, रेडियो ओपेक नहीं होता और कोल्ड वेल्डिंग नहीं होता है। सबसे बड़ा एडवांटेज ये स्क्रू को निकालना जो है आसान है और काफी जो बहुत हाई फाइटिंग स्ट्रेंथ होता है इसका, जो काफी ड्यूरेबल होता है और फ्रैक्चर हीलिंग का भी टूटता नहीं है, इसमें कोरोजन नहीं होता है और कार्बन फाइबर्स में कोरोजन नहीं होता है और कैंसर पेशेंट में यूजफुल है और स्ट्रेस हीलिंग नहीं होता है जो कि मेटल में होता है और वीक कैलस बनता है, इसमें काफी स्ट्रॉन्ग कैलस बनता है। इसका डिसएडवांटेज ये है कि इसको बेंड नहीं किया जा सकता। ऑपरेशन के समय हम लोग प्लेट को बेंड करते हैं ताकि बोन का शेप ले ले, वो मैनुअली बेंड करते हैं और उसको आप बेंड नहीं कर सकते हैं, ये टूट जाता है लेकिन बेंड नहीं होता है। सो थैंक यू। 17 years old man The road traffic accident was the mechanism of injury. Clinical presentation, a severe pain and deformity, and inability to bear the weight on the right side, whereas the left side he had a gallaging fracture. So the challenge was the patient presented with significant surgical burden and the major long bone fracture concurrent with the complex forearm fracture and dislocation, which is called the gallaging fracture and dislocation. And this is the X-ray of the femur, the sharp femur, the mid-third fracture of a 17-year-old gentleman, and the forearm gallaging fracture, severely displaced fracture. Inner canal, it was narrow, so the nailing was difficult. The standard treatment is nailing. And ideal treatment for this gallaging fracture is the plating, but I opted nailing, although it was difficult nailing in the both fracture and the slight distraction, the tense nailing for gallaging fracture, and this is not reported in any literature for such a severely displaced fracture. The tense nailing should be considered. In fact, there is no literature present for the tense nailing for this type of gallaging fracture. So we did for the minimally, because it is minimally invasive, and periosteal and endosteal blood supply are maintained in both fracture, and the interlocking nailing was done in the sharp femur, and only 9 millimeter nail could be negotiated because the narrow medullary canal. So there is slight distraction, as you can see in this picture, but we did locking. It was difficult nailing. So the goal was to provide sufficient stability for early mobilization despite of an anatomical constraint, and implant was 9 millimeter nail, and technique was minimally invasive. And whereas in this left radius, the gallaging fracture, we did tense nailing. In this case also, the 2 millimeter tense nail was used. Usually you use a 2.5 millimeter tense nail, but we use 2 millimeter tense nail. Still there is distraction at the fracture site. So this was the problem with this due to the narrow canal. But this is the 6-month follow-up. You can see I sent this X-ray in Indian Orthopedic Research Group, IORG, and they told to revise this case, bone grafting and plating for gallaging fracture. So, but I left it and wait for, this is the 8-month follow-up. Still there was better union than 6 months, but this was not hypertrophic, and this is 11 months. You can see, so after waiting 11 months, the union is complete in both the fracture. The secondary colors are been formed. It was not hypertrophic non-union. It was the union, secondary union was taking place, although it was delayed union. But this is the functional result. You can see that supination, pronation, and wrist movement, flexion and extension all are present. And the tense nailing is provides sufficient stability for secondary union even in length critical fractures, because the narrow canal and the length should be maintained to, and DR, UJ should be reduced properly. We followed the throughout the 11 months for this maintenance of the length and DR maintenance. And advantages of this minimally invasive approach for gallaging fracture and femur is minimally invasive and reduce operative time and significantly minimize minimum blood loss And with the conclusion that the TENS is viable, effective alternative for plating for the complex forearm injury. The successful management of this double fractures case confirmed that interlocking nailing of femur and TENS aids higher union rates and excellent functional outcomes. This approach should be considered for Gallagher fracture in adult after further studies, because I think this is the first case in severe Gallagher fracture. I did TENS. So this case was published in International Journal of Orthopedic Sciences.
छपरा के डॉक्टर आरसी ठाकुर ने हड्डी फ्रैक्चर के इलाज में क्रांतिकारी तकनीक विकसित कर देश भर में पहचान बनाई है। उनकी तकनीक से 35 लाख रुपए तक का महंगा इलाज मात्र 35,000 में संभव हो सका है। ऑर्थो सर्जरी में योगदान के लिए गुवाहाटी में आयोजित इंडियन ऑर्थोपेडिक एसोसिएशन के राष्ट्रीय सम्मेलन में उन्हें इनोवेशन अवार्ड से सम्मानित किया गया। यह उपलब्धि छपरा, सारण और बिहार के लिए गर्व की बात है।
इनोवेशन अवार्ड इंडियन ऑर्थोपेडिक एसोसिएशन द्वारा शुरू किया गया है, जो कि गुवाहाटी IOACON 25 में दिया गया है। और यह अवार्ड पूरा भारतवर्ष में 3 ऑर्थोपेडिक सर्जन को मिला है, जिसमें बिहार से मेरा ही नाम है। अतः छपरा जिला में जिला का कोई ऑर्थोपेडिक सर्जन या बिहार का कोई ऑर्थोपेडिक सर्जन को पहले बार सौभाग्य प्राप्त हुआ है, जिसमें मेरा नाम आया है। Hello friends, today I am going to give a demo of interlocking nailing in fracture shaft femur lower third in a 72 years old female. This patient sustained this injury due to fall on the ground. Usually this fracture occurs due to high velocity trauma in. Hello friends, I am Dr. RC Thakur, orthopedic surgeon, Chhapra, Bihar. Today, I am going to present my innovative work named Dr. Thakur Innovative Technique of Suprapatellar Nailing of Tibia. Tibial fractures are most common among the long bone fractures in human body. These are usually caused by high energy trauma like fall from height. Study shows Dr. Thakur innovative technique of suprapatellar nailing of tibia is safe, cost-effective method of treatment for metaphyseal tibial fractures. Intramedullary nailing technique is the treatment of choice for diaphyseal fracture of tibia in adults. In treatment of metaphyseal tibial fractures, concerns regarding difficulties with reduction due to anterior deformity becomes a challenge. Suprapatellar nailing becoming popular choice for treating metaphyseal fractures. It is highly specialized surgery and requires very highly specialized instruments, sets and implants that tends to be very costly. Dr. Thakur innovative technique of suprapatellar nailing of tibia delivers 100% satisfactory union of fracture in safe and cost-effective way. No special instrument or jig are required. A protective slip and a trocar can be used from PFM A to Z, and color-coded infrapatellar tibial nail extractor can be used to introduce the nail in proper position. Between March 2020 to March 2021, Dr. Thakur innovative technique of suprapatellar nailing of tibia conducted on 25 patients to fix their tibial fractures. The patients having tibial fractures with no involvement of articular surface were included in this study. Age of the patient ranged between 18 to 60 years and they had no comorbidities. All surgery were performed after an average of 5.5 days, the range being 3 to 12 days after accident. 2.5 millimeter K wire used as a blocking wire to improve nailing of proximal tibial fractures. The tibial fractures of all the patient was fixed by Dr. Thakur innovative technique of suprapatellar nailing of tibia. This is the flow diagram how Dr. Thakur innovative technique of suprapatellar nailing of tibia done. It is done in semi-extended position, about 20 degree of flexion at the knee joint, either transverse or longitudinal skin incision. We are given, but longitudinal split of quadriceps tendon done. Knee joint injured from above, proper and protective sleeve from PFNA to set inserted. Entry point is just medial to the lateral tibial spine. The guide wire, first malleable guide wire, we are introduced after serial reading, fracture reduction and confirmed by fluoroscopy, mounting of the nail with appropriate size over the color-coded tibial nail extractor done. Introduction of appropriate nail size over the guide wire done in proper position with the help of color-coded tibial nail extractor. Locking both proximal and distal done by freehand technique. No jig were used. Wash and repair of quadriceps tendon done and closure done. These are the pictures how we did our cases by Dr. Thakur innovative technique. These are the instruments, the color-coded tibial nail extractor, protective sleeve from PFNA to set, trocar and malleable guide wire and stout and hard guide wire. Reamer, these are the passage of sleeve, trocar and hard guide wire in the retropatellar space in AP and lateral view. Passage of reamer over the guide wire after percutaneous reduction with the reduction forceps in AP view, and this is in lateral view. Nail entry over the guide wire and nail entry in distal fragment in AP view. Nail entry in distal fragment in lateral view, and then both locking screw introduced in proximal fragment. In AP and lateral view, all the three screws introduced in distal fragment by freehand technique. This is the clinical picture. Proximal locking done by freehand technique. Post-operative follow-up steps. First post-operative day, passive flexion and extension of the knee and ankle joint done. Third post-operative day, active flexion and extension at the knee joint and ankle joint done. 10th post-operative day, patient started walking with the help of walker, non-weight bearing. 6 to 8 weeks post-op, we started partial weight bearing. 12 weeks operation, we started full weight bearing. Now, the final observation, operative time was in this study 80 plus minus 10 minutes. Range was 65 to 110 minutes. Average fluoroscopy during surgery was 38.5 plus minus 6.5 seconds. The range being 10 to 50 seconds. The average time of union fracture was 8 weeks after surgery, with fracture healing time was 12 weeks. Average hospital stay was 10 to 12 days. All patients followed up after 2, 3, 6 and 12 weeks. Those who could not return for follow-up, telephonic follow-ups were done and called for follow-up in hospital. No complication were observed. No patient experienced any loosening or breakage of a screw or nail. No one complained of knee pain. No reduction loss or significant displacement of fracture occurred after surgery. At final follow-up, 21 cases found excellent and 4 good results. In none of the patient, removal of nail was done for any cause. These are the results. Fracture, lower third tibia, APL lateral view, post-op, X-ray of lower third tibia, APL lateral view. Fractures, lower third tibia, again second case, APL lateral view, post-op, X-ray picture, APL lateral view. This is third case of fracture of upper third tibial fractures, APL lateral view, post-op, and this is the clinical pictures, 3 weeks follow-up. Okay. Fourth case, pre-op X-ray, upper metaphyseal fracture of tibia, and this is the post-op X-ray of upper third fracture of metaphyseal tibia. This is fifth case, the lower third, very low fracture of tibia, and this is the post-op APL lateral view. This is the clinical picture 3 weeks after the surgery. Duration of this surgery, the number of patients included in this study was small. The study was not comparative with the standard technique. The status of cartilage over the patella and trochlea post-surgery has not been evaluated. Thus, furthermore study with larger population and long follow-up time is required to compare this innovative technique with a standard technique of suprapatellar nailing. In this technique, fluoroscopy time was slightly more than the standard technique because both distal and proximal locking were done by freehand technique. Finally, friends, this innovative technique is very cost effective. In fact, no cost is incurred for this suprapatellar technique. Whereas the standard instrument sets are very costly, this technique can be adopted in smaller and medium class orthopedic hospital. If the only disadvantage of this technique is the slightly more radiation occurs because the locking both proximal and distal are done with freehand technique. But gaining more and more experience in freehand technique for locking proximal and distal tibia. Thank you. Hello friends, I am Dr. RCT Ortho, orthopedic surgeon, Sapra, Bihar. Today I will give a demo of PFN-A2 surgery for an osteoporotic patient for intertrochanteric fracture of the femur. The design of the spinal blade provides a stable fixation of this fracture and you can make mobile our patient. So today let us come to the surgery. This is the X-ray of 72 years male having osteoporosis with a fracture of the intertrochanteric on stable time. And this is the post-operative X-ray of the same patient. And now I am going to start my surgery. The skin incision, before the skin incision, I will draw a line from anterior superior iliac spine down to the table, and another line from the tip of the greater trochanter towards this first line, and the point of bisection of these two lines is the point of incision for this surgery. So I am making an incision at these bisecting points where the two lines bisect. So I am giving incision about 2 centimeters, as you can see in the picture. So I am feeling the correct point of entry. It should be at the junction of the anterior 2/3 and posterior 1/3 in lateral view, and in epi view it is just medial to the greater trochanter in the piriform fossa. So I am feeling with my fingers the correct entry point. So after feeling this, I am confirming, I am introducing a bone out at the correct point selected, and then I am confirming this whether this bone out is entering at correct selected point or not in CR picture. So I am introducing the out in correct position after confirming the entry point in CR picture, both in epi and lateral view. So this is epi view. It is entering in proper selected position, and this is inside the intramedullary canal in correct position, going medially in epi view, and this is hammered if it is in place inside the intramedullary canal in proper position, confirming in both epi and lateral view, and then I will pull this bone out for 2 centimeters to introduce the guide wire. The depression or groove present in the lateral side will guide this guide wire inside the hole and the guide wire is entering inside the intramedullary canal along the depression or groove present laterally in the owl. So it is inside the intramedullary canal, well placed in FP view. And now I will remove the owl. Also, I have removed the owl and I'm doing reading of the medullary canal. In the osteoporotic patient, the reading is not required. This is for the measuring the size of the intramedullary canal, diameter of the intramedullary canal, to select the correct size of the PFN to nail. So, but this is for measuring the intramedullary canal, and I am reading by number 10 and then number 11, remove, and the size is 11 millimeter diameter, PFN as nail selected, and then I am reading with a 15 millimeter reamer because the upper part of the nail is about 15 millimeter diameter. So I am reading this and my assistant is pushing the reamer sleeve medially so that it goes in correct position. So it has been aimed with 15 millimeter reamer, and now I am introducing the nail of selected size, and I will hammer the reamer with the help of supine. Dry. I am hammering the nail inside the intramedullary canal so that the hole present in the nail comes in the central position of the neck of the femur in AP view, and the spiral blade can be introduced in central position in AP view, and now I am giving an incision for introduction of the spiral blade, and this is the buttress nut. My assistant is tightening it, and so that it touches the lateral wall of the femur, and then I will introduce a guide wire sleeve, and a hard and a stout guide wire is being hammered in the central position of the neck of the femur, and I'm confirming it whether it has gone in central position in both AP and lateral view. You can see in the picture it is in very good place. It is central in AP view and central in lateral view also. So I am doing rimming. Some surgeons do rimming up to the lateral cortex only, but I do rimming up to the side of the nail. selected. So I have reamed up to the proper distance, and now I am hammering the spiral blade after confirming its central position in both views. And I am compressing this spiral blade by clockwise movement, and so I am compressing the spiral blade by clockwise movement and removing the screwdriver by anti-clockwise movement. So the spiral blade is introduced in proper position, both anterior and lateral view, and then my assistant is attaching the arm for digital locking on the jig. And after measuring the screw size, I am introducing the drill sleeve for drilling the vortex for digital locking. And this is the 2.5 millimeter guide wire. I am introducing, just perforating making a dimple on the lateral vortex. I am hammering this hard and stout guide wire in the lateral vortex. And after confirming it in CR picture, I am drilling with the power drill both lateral and the first vortex is drilled, and now second vortex is also drilled. And now I will put a selected size of a screw for digital locking. I am measuring this on the CR. I am measuring the size of and now I am tightening the screw, digital screw. The final tightening is done. So confirming in CR picture. The final tightening is being done now. It has been tightened. And now my surgery is over, and this is the happy view. You can see that it is in good position, and this is the lateral view of digital screw. It has been introduced in proper position in the hole, and this is the lateral view. The spiral blade has gone in the central position in lateral view also. So I will give a forceful wash of the wound, and finally I will stitch the skin and close the wound in layers. And I am closing the wound. Mr. Prashant